Good evening, everyone. How are you all? Welcome to First Aid AMC Clinical free 2-week session. I'm Dr. Arshan Ahmed, and I'm going to be the main mentor for your 5 months clinical course. So we already met, right? Because we just had a trial class a few weeks ago, and we had a very good discussion on how to start your preparation for AMC Clinical. And we went through, like, we just dissected AMC Clinical part by part to make sure you understand that how to prepare for it, and also like how much difficult it can be, but also with proper guideline, proper knowledge and everything, you can pass this exam. Have any of you have seen that in just June exam, actually May exam, how many students from first aid has passed the exam this time? So there is a lot of students, and most of them were first time candidate. So that's why we always say that there was a time when people, maybe 1 out of 100 used to pass the exam, because there was lack of guidelines, there was lack of materials and everything. But nowadays, with our guideline, with proper knowledge, with proper experience, you can pass this exam without any difficulty. It's more about knowing the facts, knowing what they look for when they pass the candidate. That's going to help you to pass this exam. So tonight we are not going to discuss a lot about AMC clinical exam, how it's going to be. You should already know if you have done the last class. Tonight we are going to do a little bit of role play. So remember last session we started the psychosocial history for psychiatry. We will catch up with that a little bit. So we will go through that just in a nutshell so that you remember what we discussed. And then we will start the role play today. In the role play, anyone, like if you are a new candidate, if you're a beginner, if you don't have much idea, don't bother. Just come and do the role play if you have a bit of an idea about this psychosocial history. Okay, so let's start. And if any of you have any questions regarding the course, feel free to ask me. We will actually do the question and answer at the end of the today's class. And other than that, just to give you an idea that basically you are doing our 2 weeks class, and the course has started from today. So anyone who is a paid member for this course, you guys are actually getting the same material, same course for the next 2 weeks, which is a big deal because I have never heard or I have never seen any other course will provide you 2 weeks free session. I always say that do free sessions, get an idea that if that course is right for you, because you never know. A lot of time people will give you misdirection. They might just say what they have actually been guided. So you should definitely come and join our all these free sessions. And if you feel like yes, this is the right course for you, if you think that all the mentors that who are discussing the classes, who are taking the class, if they are right for you, then yes, come and join the course. Otherwise, don't bother. But the most important thing is that don't waste your time and money, because a lot of time I come across to lots of candidates from different course and mentors, and they actually fail the exam because they didn't even know how to actually appear the exam like our candidate does. When our candidate do the role play, when our candidate actually go for the exam, I know that like if that candidate is well prepared, he or she will pass that exam. That I know. It's all about how much hard work they have done, because the materials that we provide, the classes that we take, that is more than enough to pass this exam in the first attempt. You don't need a second attempt, third attempt for this. So if you have heard about any other course, if you heard that no, like let's just join this course, that course, even our course, I always say that join the 2 weeks free session. If some course is not allowing you to do that, there is definitely something wrong there. So ask for the, like, can you give us 2 weeks free session so that I know how is your class? Because anyone can take 1 or 2 class, and that doesn't actually give you an idea that how good they are. Okay, so make sure to grab that opportunity and join our 2 week session. The schedules are all given in our first aid Facebook group. And definitely these classes are super important anyway, because we discuss a lot of important topics. Okay, so let's start. So for psychiatry, the first and foremost thing is to get a basic idea about psychosocial history. So to go to psychosocial history, we need to go back, because we already did that in our last session, but I think it's bit longer time. Many of you even forgot about it. So this was our psychosocial history case, which we have covered in our last class. So what I'm going to do today is to give you just a summary of this psychosocial history so that you can catch up. So if you remember that if there is any exam question asking for a mental status examination or psychosocial history, the first thing that we do is we go in, we introduce ourselves with the patient, and then give a confidentiality statement. And the confidentiality statement should be something nice, something empathic, something meaningful. It's not just like a single line that, let me assure you that whatever we are going to talk today is between you and me. It's a very conventional approach, which we don't like to use anymore. So nowadays, the idea is greet the patient politely. So let's say if it is a patient who looks a bit stressed or sad, teary, you can always start in this way. Hi Sam, this is Dr. Arshan. I'm one of the GP in this clinic. It's very nice to meet you. Sam, I can see you are very sad. I'm so sorry that you are feeling this way, but I want you to know that I'm here to help. Sam, you can tell me what's making you upset, and I'll try my best to show you the right direction. And I want you to know that whatever going through in your life, you can talk here. This is a safe place. And let me assure you that whatever we are going to discuss here is between you and me, unless it is harmful for you or others. So this is absolutely confidential. See that this is a way to start. If you start like this, there is no examiners in the exam who can fail you in the approach. If you remember our last class, approach has a specific marking in every 16 stations. So your approach needs to be really, really good. And that is the number one criteria to pass this exam. After that, you start, like most of the patient will open up at this time. So if the patient doesn't open up, just ask after a few seconds of pause, just say that, well, Sam, would you please tell me now what's going on? So always start with the open-ended question. And with the open-ended question, you might be able to find out something very important for this case. So patient will give you some information. You can start from there, or you can follow the psychosocial history format. The format is we start with questions about mood, questions about sleep and appetite. Then we go for, now remember, this is a case where the question is asking about mental status examination. So ask history from the patient. And the second task will be present MSE to the examiner. So if that is the task only, then we mainly focus on a psychosocial history for 6 minutes, and then we will present the MSE in 2 minutes. That should be what's in your mind. So we don't ask irrelevant questions in that case anymore. Irrelevant means that sometimes the question might give you diagnosis and differential at the third task. If they give you diagnosis and differential, in that case, you need to ask a lot of more questions. which means that if a patient is sad, then you need to go and ask all the relevant depression questions, like the MSE caps. If you think that, well, patient saying that I feel awesome, I feel so good, I don't need to sleep at all because I feel very energetic, that means it's going towards mania. So in that case, you need to ask all the mania questions. So that's only we needed to do it if there is a task of diagnosis and differential. If there is no task, which is most of the time, then we don't bother about these questions. We will discuss about these questions in other class. So we asked about mood, sleep, and appetite. Then we asked about the suicide risk question. I'm not going too much detail today because this is all discussed already in our last session. If any of you missed it, please feel free to go into that class. After that, we ask about hallucination delusion question. There are lots of delusion question. If you remember, we asked also the thought insertion, thought broadcasting. Then we finish with insight, judgment, cognition question. And then we go to the heads, which is basically home and work situation, especially finding out any stress there. If it is a diagnosis differential case, then we will also need to add some differential diagnosis question here. So, which you will know later on in the differential diagnosis cases. Like, let's say the same case where patient is very sad, upset. What could be the differential diagnosis in that case? Your differential diagnosis could be adjustment disorder. It could be generalized anxiety disorder, right? It could be panic attack, panic disorder. Could be acute stress disorder, post-traumatic stress disorder. So all of these will be your differential in that case. So then we will need to ask questions related to that. Like if for adjustment disorder, we ask that, is there anything particularly happened recently with you that can make you really sad and upset? We directly ask that if there is something traumatic happened with you. Because adjustment disorder always has a stressor. Usually, lifestyle stress, maybe a separation, maybe like break up with boyfriend, girlfriend, something like that. Then for anxiety disorder, we ask that, are you generally an anxious person? Do you worry about most of the trivial things in your life? For panic attack, panic disorder, we ask sometimes that, do you get an episodes where you get extremely shaky, you feel numb, you feel like someone is choking you, you feel short of breath, chest pain, you feel your heart is racing, or sometimes having a fear of death? That's usually panic attack symptoms. For ASD, PTSD, we can ask that, do you get nightmares? Do you get flashbacks of any traumatic event that happened with your life? Are you constantly anxious, fidgety? Are you constantly on guard? Okay, so you will learn about these questions because we will discuss these topics one by one in our other classes. But this is what I'm trying to say, that if differential diagnosis is a case, if it is a task, then you need to add these things. Otherwise, if it is solely a MSc presentation, then you don't need to bother. Finish with SADMA, so smoking, alcohol, recreational drugs. And lastly, finish with past medical and family history. Sometimes, if we have some time, we also try to ask any organic causes. That is also for diagnosis differential case. Okay? So to summarize, when we do a psychosocial history for MSc presentation, we start with confidentiality, mood, sleep, and appetite, suicidal thought, hallucination, delusion, ICJ, insight, cognition, judgment, heads, SADMA, past medical, and family history. That is the only thing you should have in your head, nothing else, because you will know these questions once you do a lot of role play. These questions will come into your mind. So all you remember is those points, and that format you will be using in every psychiatric case. Quickly, let me recapitulate how to present the MSE. So MSE presentation is usually to the examiner. So once you take a history from the patient, you will need to find out all this information from the patient and present the MSE to the examiner. MSE presentation has these 10 divisions. So first we talk about what is the appearance and behavior of the patient. How is the speech? How is the emotion? We talk about the perception, which is the hallucination, thought form, thought content, which content is delusion, insight, cognition, judgment, and lastly, we finish with 3R, which is risk, rapport, reliability. Now, how we are supposed to present MSE? So you will say, just give a brief introduction to the examiner that, dear examiner, I've got a 35-year-old patient who looks very sad, has some suicidal thoughts. His mic, I would like to present his mental state examination. So on appearance and behavior. Now, appearance and behavior is a really important part of MSE presentation. So whenever you get a MSE case, try to find out what is the appearance and behavior of this patient, because they will always give you some finding. So, but some specific point that you look for is, for appearance, is he dressed appropriate? Is he well-groomed or unkempt? How is his facial expression? Is he anxious? Is he fearful, sad, angry? Is he relaxed? Or is it a masked or expressionless facial expression? Masked or expressionless is common in Parkinson patient, or sometimes even patients who are like dementia patient, they can have this expressionless face. Anxious is usually patients who are quite like they're having anxiety disorder. Fearful can be in patient who has PTSD or OCD. So relaxed patients are usually those who don't care about anything. So you will always get some kind of facial expression in them. So try to include that in the behavior. Is he cooperative? So if the patient is answering your questions appropriately, that means he's cooperative. Is he maintaining eye contact with you? Is there any abnormal body movement or any abnormal posture? So depressed patients, sometimes when they sit, they usually sit with a stooped posture. Is there any frequent fidgeting of the hand? That's usually in anxiety. Mania patient will be restless, agitated. Sometimes schizophrenia or psychotic patient, you will see that they're constantly looking around, looking for, maybe they're hearing some voices. So then we say patient looks distracted and responding to some unseen stimuli. Look for any abnormal movements like tics, any involuntary movements, or any tremor. So all of these are part of appearance and behavior. So the first thing, when you say that I would like to present MSE of my patient who is 35-year-old Mike, brought by his partner because he was trying to hang himself in the garage. In terms of appearance and behavior, he is dressed appropriate to the weather, he is well groomed, but he looks very sad. He was cooperative, but he was not maintaining any eye contact. I could see that he was sitting in a bit of a stooped posture. Okay, there was no involuntary movement, there was no restlessness or agitation. So we give positive and negative as a blended in this kind of MSE presentation. After appearance, now again, if I'm getting a bit quicker, it means that we have already discussed this. So I'm just giving you a little bit of summary so that we can start the role play. Okay? So speech. We look at the speech if the speech looks normal in rate, volume, or tone. So sometimes the volume can be loud. or sometimes it can be slow. Loud volume is common in mania patient, whereas slow volume is common in depressed patient. Sometimes there might be rapid pressured speech. So the rate can be increased. So rapid pressured speech is common in mania. Okay? Sometimes the tone usually is not that important. You can just say that if there is any high-pitched tone or if there is any monotonous speech. Monotonous speech means that whatever question you ask, the answer is only yes or no. That's it. So look for the speech, whether it is normal in rate, volume, or tone, whether it is slow and monotonous, which is common in depression, whether any rapid pressured speech, which is common in mania. Then we look at the emotion. In the emotion, when we ask the patient, how is your mood? Whatever patient will give you, if the patient say, I'm all right, that is the patient's mood. If patient say, I feel low, that is the mood. So whatever patient will say when you ask about the mood, please try to write it in the paper so that you don't forget. And then the affect is what you observe in that patient. That means, what do you think about the patient's mood? If you think that, no, this patient actually looks sad to me, that means you will say the affect that I have observed is congruent with his mood. Now, there are lots of abnormal affect as well. So what are these abnormal affect? Because you will not always get a congruent mode. Okay, so there is broad or reactive affect. So broad affect means a normal range of emotional expression where an individual shows variety of emotions appropriate to the situation. Broad or reactive is a normal mode. Okay, which means that if something sad happens to the patient, he gets sad. If something fun happens, he smiles. So that is normal, broad, or reactive affect. If a patient say that when you ask a patient, how is your mood? Patients say, I'm okay. And throughout the history, you found that this patient is okay. That means his affect was congruent, or you can say his affect is reactive or broad. Okay, so normal affect is broad or reactive affect. Then we have some abnormal ones. So we have restricted affect, where patient has limited range of emotional expression and individual shows fewer emotions than expected. Labile affect, which is rapid, abrupt shift in emotional expression. So sometimes labile affect you can find in the exam. So initially patient was very angry. And then in the middle of the conversation, he started crying. And at the end of the conversation, he started smiling. He looks completely fine. This is called labile affect. So where the emotion frequently changes. Okay? So rapid shift in the emotional expression is what we call labile affect. Then we have the worst affect, which is flat. Flat is severe reduction in emotional expression with little or no facial expression, no vocal inflection, no change in gestures. So these two, restricted affect and flat affect. Restricted affect is patient is still showing a little bit of emotion. Like you will see some patients who goes through a lot of trauma in their life. Sometimes like they just becomes flat. When you ask them that how are you feeling? How is your mood? Patients say, I feel nothing. So I feel nothing. That means that there is a flat affect. Okay, so and also they will explain lots of trauma that happened in their life, but on their face, you will not see any emotion. You will not see any expression. That is called flat affect. And restricted affect is who has reduced emotion but is still showing a little bit of emotion. Okay, so it is difficult to differentiate restricted and flat affect. That's why we said we have given you a difference. Level of emotional expression is reduced in restricted. In flat affect, it is completely absent. So there is no emotion in flat. Visible expression, there you will still see some emotional expression in restricted affect, but in flat, there is no visible emotional expression. So if you get a patient in exam where patient is not giving you any information about like how is your mood, how do you feel these days, patients say, I don't feel anything. Okay, so if you don't like, that also comes with when you talk to the person, when you see the person, you will understand that what is flat. Flat means there is no expression in their face, they're just completely bland. Okay, so that's your MSE mood and affect. Perception. In the perception, we mainly look for hallucination. So lots of hallucination are there. Auditory hallucination, visual, tactile. Auditory means if patient can hear voice. Visual means patient can see something which others can't. And tactile means some abnormal sensation. Like cocaine abusers, they can feel that insects are crawling on them, but there is nothing actually there. That's called tactile hallucination. Do you know about this thing called depersonalization and derealization? You must have you must have done that in your MCQ preparation. So if someone has depersonalization or derealization, that also comes under perception. So what is this depersonalization? Depersonalization is a condition where patient has this kind of out of body experience, which means that they say that I can see a movie of myself in front of me, or I feel that my soul is not connected with me anymore. I can see myself in front of me. There is a screen in front of me. Okay? So when patients say something like this, when there is an out of body experience, that's depersonalization. Whereas derealization is a condition where patient feels that their surrounding, either it is very, very familiar or they don't know their surrounding at all. Like someone who was born and brought in Sydney, suddenly he's saying that I don't know this place. I have never been in this place. That is derealization. Or someone who never been to Australia and first time they came from somewhere to Australia and they're saying that, oh, this is where I was always been. This looks very familiar. That's derealization. Okay, so that's what we call depersonalization and derealization, which also gets included in perception. Yes, what we call as deja vu or jamais vu. So now we know about perception. The next thing is thought form and thought content. So thought form, if you can understand someone's conversation, like means you can continue conversation, you're understanding whatever they are saying, that means their thought form is linear. So most of the time in exam, you will see that the thought form they are giving you is linear thought form. But there are lots of abnormal thought form, like patient who has mania, they have flight of ideas. Patient who has schizophrenia, they have loosening of associations. So we gave you some example in our last class that how to differentiate flight of ideas and loosening of associations. Then we have thought content. Thought content includes a lot of things. So most of the time, it is the delusion that's come into thought content. So all those delusion, delusion of reference, delusion of control, grandiosity, delusion of guilt. So all of them will come here, including the thought insertion, thought withdrawal, thought broadcasting. What else can we include here? We can include any overvalued ideas, like patient who has eating disorders. They think that they're overweight, but actually they are not. They have this this abnormal body image, body dysmorphic disorder, where they feel that some part of them is ugly and that's why everything is wrong with them. So these are called overvalued ideas, which is also part of thought content. If there is any obsession compulsion, especially OCD case, which is very commonly asked nowadays, that's also thought content. Suicidal thought, homicidal thoughts, also we can include in the thought content because that's actually part of their thought. So all of this, excuse me, so all of these will be included in the thought content. Next, we just finish with cognition, insight, judgment, and then we finish with 3R. So important thing to notice in cognition, that cognition mainly we focus that whether they are oriented to time, place, and person. Now, there is a case in exam which you might have seen that they give you MSE plus MMSE together. Now, we haven't done the MMSE, so we can't discuss that case today. But just to give you fairly good knowledge about this case, that if a case include MSE plus MMSE, MMSE is completely different from what we are discussing now. So there are certain part of MMSE, and one of them is orientation. So when we will discuss MMSE, you will see that we will show you how to find out the orientation from the patient. Then we ask registration, attention, recall, language, and construction. So these are 6 parts of MMSE. If there is a case where they're asking about both MSC and MMSE together, you will follow the MSC format just like how we are doing. But you will also need to do the MMSE presentation or MMSE you need to do a MMSE or you need to perform MMSE on the patient, okay? So when you do the MMSE, you will find out whether they have any impaired orientation, registration, or any of them. Any abnormal finding that you will get in this MMSE will also be included in the cognition part of MSE. So a lot of students ask me that they're giving these questions where I need to mainly do a psychosocial history, and then quickly I need to also do the MMSE. But they're asking to present the MSE and MMSE to the examiner. How can I do that? This is how. So if you need to do a MMSE, and you will find out their orientation, registration, and all of this, any of this which is abnormal, you can include it in the cognition. Like someone who is not oriented, that definitely come here. If someone having like difficulty with registration and recall, that also you can include here. If someone having loss of attention, you can bring it here. So any abnormal finding here, that's also you can add in the cognition part of MSE. When we will discuss MMSE, I will show you that case, okay? Next, you finish with 3R, which is risk, rapport, reliability. So if a patient is actually high risk if he has active suicidal or homicidal thought, if he has active hallucination delusion, if he is like shelterless, so there is no shelter, he doesn't have any support, all of them are high risk. But the highest risk is having suicidal, homicidal thought, and active hallucination delusion. So if those are there, then you say that because my patient has active suicidal thought, active hallucination delusion, he is at high risk. I was able to maintain a good rapport with my patient, but the history that he has given is not reliable, especially in a psychotic patient. So I would like to take a collateral history from a family member. Okay, that's how you would finish the MSc presentation. MSc presentation doesn't require giving diagnosis, and they don't like it. So please do not give diagnosis with the MSc presentation. Okay. So just to summarize this aseptic J3R so that we can start the role play now. So in aseptic J3R, we have appearance, behavior, speech, emotion, perception, which is hallucination, thought form, usually linear, or look for any loosening of association, flight of ideas, thought content, mainly delusion, but still any of the others like overvalued ideas, obsession, compulsion, then suicide, homicide, all will come here. Insight, cognition, judgment. We just learned that cognition will include all the parts of MMSE also, if that's a task in exam. And lastly, we finish with 3R. And that's how we do the MSc presentation. Okay. Now, let me just give you a proper MSc presentation so that you know how to do it if some of you didn't do our last class. And then we will start the role play. So let's say this is a patient who is sad or depressed. Okay. So, dear examiner, I would like to present the mental status examination of my patient Mike, a 35 years old patient who was brought by the partner because he was trying to hang himself in the garage. In terms of his appearance, he is dressed appropriate to the weather, well groomed. He looked sad, but he was cooperative but he was not maintaining any eye contact. His behavior was a little bit, you can say that as part of abnormal movement, he was sitting in a stooped posture. There was no restlessness, agitation, or fidgeting. His speech was slow and monotonous. There was no disorganized speech or rapid pressured speech. His mood was low, and the affect I observed is congruent with his mood. He did not have any hallucination. His thought form is linear. As part of thought content, he had delusion of guilt because he believes he killed a patient under his care. He did not have any other delusions. There was no thought insertion, withdrawal, or broadcasting. He is oriented to time, place, and person. His insight is lost because he wants to harm himself or he wants to suicide. His judgment is impaired as well. He is a high risk patient because he has active suicidal thought. I was able to maintain a good rapport with him, but the history he has given was not reliable given his lack of insight and judgment. So I would like to take a collateral history from his family member. Thank you, examiner. That's how you present MSA. It has to be very smooth and blend of positive, negative findings. That's how you have to do it in exam. Okay? And in our last class, we have done a role play, and I've shown you how to take history and how to do the MSc presentation out of it. So let's do role play on MSc now. So who wants to do the first role play? Dr. Arthi, okay. So let me unmute you and let me just blur this screen so that I can give you the case. So for this role play, how we normally give you the time is you get 1 minute time to go through the case, and then we do 7 minute 30 second for the case. In your real exam, you don't get more than 7 minute 30 second because you lose some time. So you might get 7 minute 45 second in exam, although it is a 8 minute station. But you will be talking to the examiner, you'll be introducing yourself with the patient. So there will be some loss of time in that 8 minute. So when we do role play, we will always do it as 7 minute 30 second. Okay, and you will get 1 minute to read the case, but in actual exam you get 2 minutes. So Dr. Arthi, you can unmute yourself now.
Hello, doctor. Good evening.
Hello, doctor. Good evening. So this is your case, Dr. Arthi, and we will start after a minute.
Sure.
And just for tonight, because you need to talk about the appearance, so just keep the appearance part as well-dressed, kempt, and so just keep this like this. The patient is well-dressed and well-kempt. That's it. Okay?
Sure.
All right, Dr. Arthi, your patient name is Sam. You can start.
Okay. Hello, Sam. I'm Aarti, one of the doctors in this GP clinic. How are you doing today?
Yes, yes, I'm okay.
Okay, Sam. Yeah, I understand you're feeling a little anxious, and I'm here to ask you a few questions about that. Is that all right with you?
Yeah, what do you want to know? I just,
Yeah.
I can't
So,
stop
yeah,
thinking about it.
okay. Sure, Sam. And yeah, it's all like I would like to assure you that whatever we discuss here remains confidential unless it causes harm either to you or to others. So you mentioned you can't stop thinking about something. So may I know what it's that?
I don't know. You will think me as a creep. I can assure I'm not a creep. Just like I can't stop thinking about it. Why I can't stop it? Stop my thinking.
Oh, okay. I'm so sorry to hear that, Sam. So what are you thinking about? What are these thoughts? May I know?
I just can't say it to you because you'll think me I'm a psycho.
No, Sam, we don't judge you. I don't judge you. So don't worry. You are free to tell whatever you feel like. But may I know, like, how was your mood these days?
I just feel quite anxious these days because these thoughts keep coming in my mind.
Oh, okay, sure. And okay, has it been same all the time? You feel anxious all the time, or you feel anytime feeling low or
No, I don't feel low, but I just hope these thoughts are just getting ended because this is just too much for me now.
okay, sure. And does that affect your daily life as well?
Yeah, I can't do
Hmm.
anything about it.
Hmm.
That all the day and night, I just keep on thinking about it. I know it is not
Okay,
right.
sure. I'm so sorry to hear that, Sam. And does that affect your sleep as well?
No,
No, okay. And I'm so sorry to ask this, but this is just a routine questioner. So, do you think life is worth living, Sam?
yes, I do.
Any thoughts of harming yourself or harming others by any chance?
No, never.
Okay, that's okay. And do you see, feel, or hear things which others don't?
No, no, I'm
Okay,
not insane, doctor. I can assure you, I'm not a
okay.
mental.
Sure, sure. Oh, okay, Sam. It's just, as I said, it's just a routine part of my questionnaire. So I'm just asking you that way. So those thoughts you said that keeps coming in your mind, is that like somebody is telling that thoughts or you are hearing some voices? Just that's what I asked you. No?
Yes, I know. It just this thought is like I keep on
Mm-hmm.
getting these thoughts as my mom is having sex with my uncle. Oh,
Mm.
I know it is not right, but I can't stop it. I wish there was a switch button in my brain and I could just forget.
Okay, okay. I'm so sorry to hear that, Sam, but don't worry. Is there any reason, stressful event or anything that happened before this to make you think this way?
No, because I don't know why, because even my uncle did not see us for the last 5 years. We don't even be in touch with them.
Mm.
So
Mm.
why this is happening, I don't know.
Okay, sure. Do you think anybody is inserting thoughts into your mind
No,
or anybody is withdrawing thoughts from your mind?
no,
Do you think somebody is like any other people are talking about you or trying to spy on you
no,
or trying to harm you?
no,
Do you think that you have any special powers?
no, I wish I had.
Okay. Do you feel anything special about yourself? No?
I don't know. I have this thought which I also like don't understand. I feel like I constantly need to wash my hand uh,
Oh, okay.
because because if I don't wash, I believe that there
Mhm.
might be aliens in this world who will kill everyone. I know what
Okay.
you are thinking, Doc, but I know these are not right thoughts.
Mm-hmm. Okay. And do you think the aliens are going to kill you as well?
I think everyone will be killed. I don't know about me.
Okay, sure. And do you think that these thoughts are unreasonable?
Yes, I know, but I just don't know.
Mm-hmm.
I know these are not
Have,
reasonable, but I can't stop
okay,
them.
sure. And have you thought, I mean, you thought about stopping them, but you still can't stop them. Okay. And does that affect your
Yeah,
daily life as well? Okay.
yeah,
Do you think your thoughts are being broadcasted in TV or television?
no,
No. Okay. Do you think you need medical help, Sam?
yes, I think so.
Sure. And this is just a hypothetical question. What will you do if there is a fire in this room?
I'll just run.
Okay. And do you know where you are at the moment?
Yes, in the hospital.
And who am I?
You're the doctor.
And do you know what day it is today?
Sunday.
Okay,
Go to your next task,
sure.
doctor.
Okay, sure. Um, Thank you, Sam, for the history. I'll present my examination findings to my examiner. So, examiner, I would like to present the MSE of my patient, Sam, coming in with the history of feeling anxious. Appearance, on observing the appearance, the patient is well dressed, well kempt, and also dressed appropriately to the weather. On behavior, fidgeting, excessive fidgeting is noted. Patient looks restless, as well as eye contact wasn't assessed. The speech, on assessing the speech, the rate, tone, and volume seems little pressured, and the tone and volume seems normal, but still the rate is pressured. Mood, when assessing the mood, the patient feels anxious, and the affect that I observed is congruent with the mood. And there is no auditory, visual, or tactile hallucinations. The patient's thought form looks linear. The patient's thought content has some overvalued ideas of thinking that his mom is having sex with his uncle as well with her uncle, as well as he's having some obsessions of frequent hand washing because he's thinking that some aliens are going to kill people. So the assessing the thought content, there is no delusion of reference. I mean, there is no delusion of reference, control, or grandiosity or guilt. But he's got this persecutory delusions regarding the aliens. There is no thought insertion or thought withdrawal or thought broadcasting as well. Insight and judgment seems intact, and cognition is intact as well. I was able to maintain rapport reasonably with the patient, and there is no risk of self harm as well as harm of others. But still, as the patient has got this delusional thoughts, the patient is at moderate to high risk. So,
Time on, doctor.
the thank you.
Thank you. Thank you, Dr. Arti. Brilliant. You've done really good. So I think like, yeah, it's well done, MSA. You got most of the information that we want in here, but
Sure.
just few things I think like you missed. So
Mm-hmm.
let's see that if anyone else can find out that what was missed in this case, especially during the history. What else we could ask here?
And maybe what else do you do? Like he said about the obsessive compulsion regarding washing hands. So, do you do anything
Mhm.
else at all? And some
That's
organic
it.
condition, obviously, organic
Hmm.
condition, doing out head injury, infections, thyroid, or any family history of mental health conditions.
That's fine. Because you didn't have that time to do that. Those are
Yeah.
not the most important. And
Mm-hmm.
differential diagnosis is not a task. So those are not most important to find out the other differential in here anyway. But my main thing that I felt that you missed is asking about the compulsion. You got
Mm-hmm.
a obsession. There is a lots of obsessional thought. Does he do any
Mm-hmm.
compulsive behavior? What he
Mm-hmm.
when he get this thought that his mom is having sex with uncle, does he need to do anything? Because
Mm-hmm.
if you ask me, I would say that yes, every time that thought comes in my head, I need to stand up and I just need to run around this room.
Mm-hmm.
So that was one of the most important finding that you missed. Okay.
Sure.
So
Yeah.
always remember that if there is an obsessional thought, then there is a likely chance there is some compulsive behavior. Now, if I was not giving you that I need to wash my hands, then you would not ask it. I gave it purposefully, but in exam they will not do it. They will
Mm-hmm.
just not inform that part to you at all because you didn't ask it. So
Mm-hmm.
it's an important thing that when we are going into obsession compulsive, so understanding what this case might be, that gives us a lot of information that where we should look. Like from here, when we talk, when first time when you talked, you knew that there are some thoughts. And when there is a thought, and I keep on saying, I know that these are not right, immediately you would know that this is a OCD case. So your
Okay.
questions should focus on a little bit more towards OCD as well. That means you know in your head that, well, this might be OCD. So I know there will be an obsessional thought, there will be some compulsive behavior. Definitely, yes, you asked about how does it affect your life, which is really important. Then also, do you need to do any other repetitive behaviors? Do you have any other abnormal thoughts? So when you ask more, they will give you more. Otherwise, these role players will not give you any extra information in this case. These are very restricted case because MSc case is like that. If you don't ask, you don't get. So other than that, I think like you asked all the important information. So you started with like proper reassurance. You gave the confidentiality. Your approach was really nice, Dr. Arthi, how
Okay.
you gradually went into the case by case. When I was not giving you the information, you did not bother. You started the format, which a lot of candidates will not do because they will just constantly ask, what's your thought? What's it? So sometimes the role player might not feel like giving it to you immediately. Once you start building up rapport, they might give you that information that you want. So if you're not getting some answer, don't stop. Ask it again in the middle of the conversation. They might open up and give it to you then. Okay? Because
Sure.
if you did not ask it, then then you just miss that whole thing. And you could say that I asked about it, but patient did not give it to me. that is not enough for this exam. Some of the patient, especially psychiatric patient, does not like to just give their thoughts to a unknown person immediately. It needs time to build a rapport with the doctor. Okay, so it's very common that you will not get everything when you ask. So do not stop. If you think that it is a patient um, who has psychosis, definitely it's worth exploring all the delusion and everything because there will be something there. Now, apart from that, I think the history, although you did not get enough time to finish all the things, it will not fail you because you asked the important history. That is enough, except the compulsive behavior.
Okay.
Now, for MSc presentation, I would like someone else also to present this MSc, just to know that if there is any different finding you guys are thinking than what Dr. Aarti has given. Is there anyone who would like to give just the same case? You just present the MSc. Anyone? No one? So this is the easiest task, right? So you already know everything. I just want to see that if there is something else you want to add here. Okay. All right. Let me explain then. So how we would do the MSc presentation for this particular case. So did you write aseptic J3R on your paper, Dr. Aarti?
Yeah, yes, doctor. Yeah.
You
When
did.
I
Very
was
good. Yeah.
starting
Yeah.
the case.
I, I,
Doctor,
I
just sorry to
understood that. Yeah.
interrupt. I have a doubt. So we have
Mhm.
seen that in the STEM, it's mentioned as she is anxious. He's coming in with anxiety, but still the second task is mentioned that we have to present the MSc. So we are knowing that it is a psychiatric case. So it's obvious that we need not go in detail about the anxieties in it, because if we have to talk about the anxiety, we have to rule about the organic causes and everything. So, but
Mhm.
should we go in that approach, or we have to have it in mind that this is a psychiatric case, so we'll go ahead and do that aseptic J3R format itself, or should we think
It's
about the
always
anxious?
it always depends on the task. Task determines what you will include in your
Okay,
history.
sure, doctor. Yeah,
Okay,
that
so
sounds
it
good.
doesn't
Okay,
matter. Like I know that we should ask about all the anxiety differentials and all, but is it your task? No. So if
no,
you
no,
don't get enough time, that's totally fine because they will not mark you on the basis of that. Okay.
sure, no,
It's definitely in like if someone do that, it's really good. They will get a little bit high mark, but if you don't do it, you will not fail. Because if you
sure.
would ask all the questions of anxiety differential, you would not be even able to start the MSc presentation and you would fail the case. So it's better
Yeah,
to get 4 in MSc history and then get another 4 in MSc presentation and pass that case than getting a
okay,
6 in a history and 0 in
sure.
MSc.
Yeah. And if the patient is not giving me his thought contents, like where do I really ask him? Like when I go to the T part, I will ask him, like, can you please explain me more about the thoughts? What are your thoughts?
Yes.
And just little bit more. Okay,
Mm.
sure.
Yeah, so
Yeah,
in the
thank you.
thought form or in the thought content, you will again start asking these questions. So you told me about these thoughts, which is unreasonable to you. Can you describe those thoughts to me now? So
Okay,
this is the vital part of this case. You will need to explore it. Okay,
sure, doctor. Yeah, thank you so much, doctor.
thank you. So we will start in this way. So you will say that, dear examiner, I would like to present mental status examination of this patient who is, let's say, 35-year-old patient who is being very anxious these days. In terms of his appearance and behavior, he is well groomed and well kept, was not maintaining eye contact all the time, but he was showing this frequent restlessness and fidgeting with his hand. In terms of his speech, the speech was a little bit high and low throughout the conversation. There was features of pressured speech, but there was no disorganized speech. His emotion, he told that his mood is he's feeling anxious and the affect I observed is congruent with his mood. There was no perceptual disturbance. His thought form was linear. In terms of thought content, he had these overvalued ideas where he had this obsessional thought that his mom is having sex with his uncle, although he knows that this is not right. And he was also having a compulsive behavior that every time he has this thought, he need to get up and just run around the room once. Not only that, he also had another compulsive behavior that he needs to do a frequent hand washing. On the top of that, he had this magical thinking where he thought that if he doesn't wash his hand, aliens will come into the world and kill everyone. There was no other delusion, no delusion of persecution, no delusion of reference, control, thought insertion, or thought withdrawal. His insight, cognition, and judgment was normal. He is in a bit of moderate risk given that he has these active thoughts, like active thoughts of magical thinking. But again, he knows that these are wrong, so I'm not very concerned about him. I was able to maintain a good rapport with him, and his history seems to be reliable. Thank you. So as you can see, the only thing I changed in here is the thought content. So if the patient say that, so OCD patient has this kind of abnormal thoughts called magical thinking, which we haven't discussed in the MSE yet. So magical thinking, there is a specific thought that we get in OCD patient. Let's discuss that. And those thoughts are quite unusual, quite abnormal, like aliens coming in here, something like that. Okay. So what is magical thinking and why it is not delusion? Because delusion looks like the same, right? Like if I don't wash my hand, aliens will come into the world and kill everyone. Why it is not delusion? So magical thinking is belief that one's thoughts or actions can influence an event. That's why it is. I told that if I don't wash my hand, something will happen. So if someone believes that my thought or my action influence certain events, that's magical thinking. For delusion, you don't need to do any action. Your action doesn't matter. You believe something that you are strongly hold that belief, even though there are lots of reasoning and evidence, you will still believe that. But that belief does not stand on the idea of your action or thought. Doesn't matter whether you wash your hand or not. Okay? So there is the magical thinking, and magical thinking, their belief may not be strongly held. As I said that I'm not sure. I know this is unreasonable. That's why it is not delusion, because if it was a persecutory delusion, I would say that like I think like aliens are after me. They want to kill me. That is delusion of persecution. But I did not say about me. I say that if I don't wash my hand, aliens will come to this world and kill everyone. So that means if I don't do hand washing, so my action can influence event, which means alien will come to the world. Does it make sense to everyone? So this is commonly associated with OCD sometimes. So that was one of the finding in this case, apart from all the overvalued ideas that we talked about. Okay. So in here we say that in terms of thought content, he has obsessional thought. We explain what is that. And whenever he has this thought, he needs to stand up, move around. So he's also having the compulsion. He's having this magical thinking that if he doesn't wash his hand, aliens will come to the world. And others were all good. And this kind of patient who has OCD, they are not high risk because they know what's wrong. So they have insight, their judgment is fine. So you can say that they are low to moderate risk. So not a high risk for this case. All right, everyone, any questions with this case? Anyone? Brilliant. So if we can't build a rapport, then just say that I was not able to build a good rapport with the patient. That's fine. You can always say that. It's not a problem in the exam. Okay, who wants to do the next role play? We'll show you a video MSc now, because nowadays I see that there is a lot of video MSc coming in the exam. So video MSc works like this, that they give you a video of two-person like a doctor and a patient having the conversation, and then you need to listen to the video and also watch the video for 4 minutes, and after 4 minutes you need to give the MSc presentation to the examiner, which is quite easy than taking all this history. But again, if you miss even a tiny little thing in the video, they will fail you. Yes, it happens in face-to-face exam as well. So it was commonly given in online exam, but nowadays even with face-to-face they give it. Even when I used to prepare for this exam, it's still, because that was the time when face-to-face exam was there, still this used to come. So they have this kind of like a big screen where they will play the video, and then you just need to, the examiner will be there in the room, you will watch the video in the room, and then you need to present. So it happens in face-to-face as well, not just online. Okay. All right, so let's see who we want to start. So Dr. Ben, you were next. You can unmute yourself.
Hello, doctor.
Hi, how are you?
Yes, good evening.
Good
Yes.
evening, doctor. So let me give you the case. Okay, so this is your case. Just read the case, Dr. Ben, and after that we will start with the video.
Okay, you may start the video.
Hi Andy, do you want to come on in and have a seat? I'm Dr. Taylor, I'm the on-call psychiatrist for this afternoon. I got a call this morning from your family doctor because I think you went to see him this morning along with your mum, and I gather that things have been a little bit difficult for you. You've had some rather distressing experiences. So I think your doctor thought it might be helpful for us to have a bit of a discussion about that to see if I could help. Would that be all right with you?
No, it's fine.
Would it be all right, Andy, for you to tell me a little bit about what's been going on?
Well, you're going to think it sounds stupid, but my housemates are working for MI5.
Right.
And they're doing stuff to my brain.
Okay.
And they're out to get me.
Okay, that must be very difficult for you.
Okay.
How long has this been going on for, Andy?
About 2 months.
Right. And how did you first work out that this is what was happening?
I came home one time and they'd moved the TV to the other side of the room, and
Right.
I knew then
And what was it that you knew at that moment?
that they were for MI5.
Right, okay, okay. So it's been going on a couple of months.
Yeah, this new lecturer started at uni, and he works for MI5. And
Right.
he basically drafted my housemates in, turned them against me.
Okay. Yeah. Okay. Now I've noticed a couple of times while we've been talking that you've sort of looked round you into the room as if you're checking for something. Could I ask you what's happening at those times?
Well, I can hear them talking about me.
Right. Who is it you can hear?
My housemates.
Right. So that you recognise it as their voices?
Yeah, I can hear them all the time.
Right. How many voices can you hear, Andy?
3. There's 3 of them.
Okay. And do they sound real, like my voice sounds talking to you now?
Yeah, it's odd. It's like I can hear them when they're not here.
Right.
And
so what they're not when they're not in the house with you?
yeah, it's like they're in the other room or something.
Okay. Okay. And can you hear what they're actually saying?
Yeah, they're talking about me.
Right. Okay.
They're always talking about me.
Okay.
They're always commenting on everything that I'm doing.
Right. Can you give me an example of what they would say?
Well, like if I'm packing my bag to go to uni or something, they'll comment on that, like he's left the house now. Or,
Okay. Okay.
you know.
Anything else? Do they ever talk to each other, perhaps about you?
Yeah, that's what they do. I mean, and now they know. They've sort of twigged that I know about them now,
Right.
and they're saying like I'm making trouble,
Okay.
and that they're going to sort me out.
Okay. Okay. What about actually talking directly to you in the way that I'm talking to you now? Does that ever happen, Andy?
No.
Okay. So you've been hearing the voices of your housemates. Have there been any other changes? Have there been any changes perhaps to the way you're thinking? Sometimes people tell us that their thinking changes in some way. So, for example, they might feel that they're getting thoughts put into their head that aren't their own. Have you had any experiences like that?
Yeah, I do think things that aren't me. Like
Okay.
they're putting stuff in my brain. It's not me. I'm not thinking.
So different
like
thoughts in your brain.
Yeah, that's
right.
like it's stupid stuff as well. It's like the other day I suddenly just started thinking about some woman in Coronation Street. I don't watch any of that crap.
Right. So it's not your kind of thing normally. Right.
They're not my thoughts.
Right. Okay. And do you have any idea how that's happening, or who's responsible?
It's MI5. It's this chip they've put in my head.
Right. Okay.
And I can feel it all the time.
Okay. So you're getting thoughts put into your brain that aren't your own. What about a different sort of experience? What about the experience that somehow other people are able to know what you're thinking, even though you haven't actually told them?
No.
Nothing like that?
They're just putting stuff in my head.
Just putting stuff. And can I just check, Andy, as well, that you're not getting the experience when your thoughts just stop altogether, like you have no thoughts left?
No. If anything, there's too much in there. I wish I could unplug it.
Okay.
Just get this thing out of my head.
Right. And you mentioned this chip or this device in your brain. Do you want to tell me a bit more about that?
Well, it's a tracking device, so they know where I am at all times, and I can feel it moving around, like rotating
so you
around.
can feel the physical sensation in your brain. Okay. That must be very difficult for you.
I don't know why they're doing this to me. I've done nothing wrong.
Okay. Can I just check, are there any problems, Andy, with the rest of your body? Any changes in sensation or any bits that feel different in any way?
No, I feel fine. I'm not ill or anything. I just want this thing out of my head.
Okay. I mean, it sounds like a very difficult time for you. Can I ask you, Andy, how are you coping with all this? How's it affecting you?
Well, I'm not really leaving my room much, and I sort of have to wait till they go out to go down and get some food. But they've been doing stuff to my food now. So
okay. Well, what do you think's happening to your food?
They're poisoning it.
Right.
All right. So Dr. Ben,
Yes.
get 2 minute time to just to like present this MSE. In exam, you'll get more, but we just do it in 2 minutes so that we know that how you're doing. Okay. So I'm just going to start your 2 minutes. So you can start now.
The examiner, I would like to present my patients, 30-year-old man with problem with his with problems when he hearings people talking about him. So first, his appearance. My patient is dressed appropriate for the weather, his workroom, and he has a kind of anxious and angry facial expression. He's quite cooperative. He sometimes he doesn't maintain eyes contact, and he has kind of restless body movement. Uh, about the speech, his speech is kind of rapid and pressure. He doesn't have an slow or monotonous rate, and according to his emotion, he's quite anxious, and the effect is the effect I observe is congruent with his mood. He has some kind of auditory hallucination. It is about his three housemates talking about him, and sometimes they put thoughts into his head, uh, just as if there's a chips in his head, and he's very quite upset about this. They he thought they also poison about his food, so make him quite anxious. And his thought form is linear. He doesn't have any loosening of.
I'm out, but you can
Yes,
continue. Continue, Dr. Ben.
yes. He doesn't have any loosening of association thoughts form of like concrete thinking. Um, he says he doesn't have any delusion. Oh, he has delusion about he about his housemate is talking about him or trying to harm him. Um, he doesn't have any suicidal thoughts or overvalued ideas. His insight is poor, and the patient is oriented to person and place and time. His judgment is kind of poor, and his risk of suicide or homicide is moderate, and I was able to establish a good rapport with the patient. He appeared distressed, but uh, it I was able to build a good rapport, and the history given was reliable, and I doesn't need to request a collateral history from any family member.
Okay.
Yes.
Thank you, Dr. Ben. All right, you tried your best, which is really good. I appreciate this always because I know you are a beginner. I know that you have tried and you might not even got a lot of time to finish everything, but you did the try, which is really good, Dr. Ben. So
Thank
my
you.
advice for you would be to be a bit faster. So it will become much more easier once you start doing role play with your study partner. But because I know that like how you will run out of time with this rate. So my first advice would be to be a bit faster. And other than that, like you are covering all the important things, which is really good. But just just do a lot of role play. And with lots of role play, you will also improve with your like how you're talking, how you like your confidence will come into your voice. We know that when someone do a case, we know just by their voice that whether they are beginner or whether they are like middle of their preparation, and examiners know the same. It's just an experience because I've been doing role play forever, I think last 7, 8 years. So I know that like how gradually you will also improve. So the improvement needs more and more role play. If you do role play on this case again, like just just do like when you finish this class today, if you do the case again, you will see that you were able to finish it in 2 minute time. It's all all comes with role play and practice. So please continue the practice and you will be totally fine, Dr. Bain. Now, I want someone else to also do this, just to see that if there is anything different that you can add. And I will go along with you. So let's say that if we write all this as aseptic J3R, all right, let's see what you can say about this case. Anyone else? Dr. Jana or Dr. Anna? Yep. Just you can unmute yourself.
Yes, Dr. Asha.
Hello, good evening.
Yes. Yes, Dr. Anna, you can start.
Yep. Okay. I would like to present you my patient mental state examination. He is 20-year-old student and he's struggling with voices. He is dressed appropriate to the weather, well groomed. His facial expression is a little bit flattened, but he is cooperative. He is maintaining poor eye contact, and his body movement a bit suppressed. His speech rate is pretty normal, but volume is quiet. He taking pauses sometimes. His mood is anxious, and effect I observed is congruent with his mood. He is experiencing auditory hallucinations. He is hearing voices. Also, he believes that he has MI5 chip in his head. His thought content, his thoughts is about he is hearing voices of his mates, and these voices are about himself. He has poor insight, and but sorry, we don't know about his judgment because she didn't ask. Yeah, is it?
Yeah, that's right.
All right.
Yep.
Yeah, and also we didn't know about cognition as well. I mean, orientation to time, place, person, because she didn't ask as well.
Okay. If something is not asked, you just say it hasn't been assessed. Okay.
Oh, okay, okay.
All
Okay.
right. So it's still, I'm not finding out all the information I want. What else is missing? Anybody? Janan? Yes?
2 months. He has been experiencing it for 2 months.
That's all right. It's still something is missing, Anna.
Yeah, so Dr. Ashan, you want me to start from the beginning, aseptic J, yeah?
Yes, Dr. Jana, start
Okay.
with that and we will go from there. Let's see.
Okay, 2 minutes, yes, please. So, examiner, I'm presenting a mental state examination of a patient, Andy. He is 21 years old. He came because he has an unrealistic, something happening with him. So, on appearance, he is appear like well dressed, well groomed, according to weather. His behavior was fidget in behavior. He was rubbing his hands. He is wearing a black jacket and black jacket, and he was well dressed, well groomed. You mentioned that, and he was maintaining eye contact in between. He was cooperative, and he was anxious in behavior. His speech was monotonous. in rate, but was normal in tone and volume. His his emotion was congruent with affect. So if his mood was anxious and emotion was congruent with it. He has persecutory auditory hallucination. He deny any tactile and visual hallucination. So auditory hallucination of three housemate was speaking about him, and that was abnormal hallucination to him. And his thought forms was linear, and his thought content was abnormal thought contents of someone inserting a thought insertion, and a thought insertion the content, and he deny any withdrawal thoughts, and he deny any persecutory or controlling thoughts or guilt, and he deny any grandiosity or broadcasting thought. His insight is he doesn't have any insight, is poor. His cognition and judgment was not assist. His risk of suicidal was not assist or homicidal. He thinks that the flatmate was putting a poison to him. So this is like kind of someone want to harm him. So thought insertion or thoughts of someone want to harm him. And I think he is at risk because he is lost inside. And I want a collateral history from the family. And he is at risk, high risk, for mental condition. And I need a reliable history. Thank you very much, examiner.
Thank you, Dr. Janab. All right, still, you have added few things. That's good. Still there is few things left. So tell me, like, yes, Dr. Hassara, delusion of reference, persecutory delusion or paranoid delusion. Yes, we have got more. So yes, this patient has got delusion of reference because he keeps on mentioning that like everything that he is doing, like the neighbors are commenting on it. So if anytime patients think that like someone is commenting on all my activities, that's a reference as well. Definitely, I don't know like why still now no one talked about delusion of persecution or paranoid delusion, because that was all over the place. So he keeps on thinking MI5 people is after him, someone is poisoning his food. So there was definite paranoid or persecutory delusion all over this conversation, right? What else? Dr. Hassara, what do you think? What do you think? Like, I'll give a little bit more clues.
Was there a component of derealization, Dr. Ashan?
No.
I felt it at some spot.
No.
Sorry, Dr. Ashan, a visual hallucination? He was seeing something when he turned his head like that?
No. No, because it was about like hearing the voices. He was not actually seeing anyone.
Yeah, it was deny any tactile or visual. Yes, we mentioned that.
So there was a tactile hallucination in here.
But
Why?
she asked him, do you feel any nerve and numbness or tingling or something? No, he told no.
So the tactile hallucination is he was saying that there is a chip in his brain. He can physically feel it. But there is no chips in his brain. That is tactile hallucination. So remember when the doctor was like being sure that yes, you can, I can feel a chips in my head. So then the doctor asks that, do you physically sense it, that it is there? That is a tactile hallucination. So that's what I'm looking for, that whether you guys are getting that tactile hallucination from this. Okay? So I think that's all we have got in here. There was another thing. So you talked about thought insertion, so that was there. So let me explain how we would do this case in this patient. So let's say this is a 30-year-old having some behavioral issues. So we'll say, dear examiner, I would like to present MSE of Sam, who is a 30-year-old patient with behavioral change. In terms of his appearance and behavior, he is well dressed. He is dressed appropriate to the weather. He was cooperative. He was not maintaining eye contact throughout the conversation. Sometimes he was looking at the doctor, but most of the time he was not. I could see that he was having a bit of a stooped posture and looked a bit anxious. He was also responding to some unseen stimuli because he keeps on looking all around the room for something or someone. His speech was variable in tone, volume, and rate. There was sometimes it was a bit pressured, but there was no slow, monotonous speech. There was no rapid, loud speech. His emotion was not assessed fully, but he looked anxious, and the affect that I have observed looks like he was anxious, and it is congruent to his mood. As in terms of perception, he had auditory hallucination because he could hear all the neighbors talking about him. He is also having tactile hallucination because of the physical sensation of a chip in his brain. His thought form is linear, but in terms of thought content, he had thought insertion. He has delusion of persecution because he thinks MI5 is after him. He has delusion of reference because he thinks all neighbors are constantly commenting on everything that he is doing. His insight, judgment, cognition was not assessed, but it looks like his insight might be poor from the conversation. The doctor was able to maintain a good rapport. He is in high risk because of active hallucination and delusion, and we should, like, the doctor should ask for collateral history from the neighbors for further clarification. Thank you. That should be your MSc presentation in here. That will cover almost everything that this patient has. Now you can understand that it looked so easy. Just a video conversation, no history taking, nothing. Looked so easy, but so many things in a single case. And unfortunately, these are the cases where candidates fail most of the time because they will always miss something, like most of you missed. So someone was able to say this, someone was missing the this. So always there is a bit of a missing there. And that happens in most of the time in exam who fail this kind of case. So it's really important when you get a video MSc case, don't get super happy that it's going to be easy to pass. It is one of the cases where most of the candidates fail because they are very strict about this kind of case. Okay? Derealization, depersonalization. Derealization is it's kind of a thinking where patient believes that he has this out of body experience, which means that if I say, if my patient says that, doctor, I feel that I can see another version of myself in front of me, okay, or I feel I'm not real anymore. That is how depersonalization patient will say. Whereas derealization patient, they just have this thinking of familiar things becomes unfamiliar or unfamiliar things becomes familiar suddenly. That's derealization. Yes, good question, Dr. Vambe, that this is a conversation between a doctor and patient. So you will always say the doctor established good rapport, the doctor should do this. So that will be how we are going to present. Always remember that do not just add something in these video pages that is not being assessed at all. Like definitely cognition judgment needs to be assessed. Without that, you don't say that I think this patient's cognition judgment is impaired. You don't say anything that you think in this kind of case. But insight, you can say that although it is not assessed, it looks like his insight might be poor. See that how we are doing it? We are not sure, but it looks like it can be. That is okay to say. But you can't say insight is poor because it was not actually assessed in that way. In the same way, emotion, we didn't ask how is your mood. So you would always say as part of his emotion, the mood was not assessed, but it looks like patient is anxious. And the affect I have observed is also congruent with this mood. That's how we will need to narrate this. Okay, so if something is not assessed and you're saying it, always say that it was not assessed, but this is what it might be. Okay. Let's do another case. Who wants to do the next case? Okay, Dr. Sarah, you can unmute yourself.
Yes, doctor.
Okay. Just give me 1 minute. I'm going to give you the case. Start after 1 minute.
I can start.
All right, just 1 second. All right, this is Sarah. You can start.
Hi, Sarah. Nice to meet you. My name is Sarah, the attending doctor here for you today. I'm sorry about what happened to you, but I think you are stable now and ready to go home. But before you go home, I would like to take some further history, and I wanted to assure you everything will be confidential. Would that be right with you?
I don't care. You just let me go home because I'm done. I'm done with the hospital. I'm never coming in here. This is a shitty place. So just let
I
me go
see.
home. I have been already cleared by your other doctors. Can I just go home?
Yes, I can't understand what are you feeling now, but I want to assure you that I'm here to help you, and I just want to take some minutes so I can assess your mental state. Would that be all
I
right?
don't need anyone's help. How many
Yeah.
times I have to say that I don't need anyone's help?
Okay,
Everyone is
Sarah.
trying to say, everyone is trying to say that they can do something for me, but
I
it's not the
understand how much
case.
you are. Yeah, I can understand how much you can feel now, but I can try to talk to you or can guide you for some help if I as I possible as I can. Would that be right?
Whatever, go for it.
Okay, Sarah. So I can see that you have taken some diazepam tablet, about 10 tablets, and I would like to know, would that you wanted to kill yourself or just want to give attention?
I just wanted to show him that how much I love him.
Yeah, I see. I'm sorry about this. It must be stressful to you, but was it the first time or did it happen before?
Yeah, I did before,
How many times?
maybe 10.
Okay, was the same tablet or overdose as well?
Sometimes I do a few other things. I cut my wrist.
Mm-hmm. Okay. And did you feel happy, or I mean, did you feel guilty after this, or you feel relaxed after doing this?
Yeah, I don't know. I don't feel anything. These days I just don't feel anything anymore. This is This is not
You
good.
you don't regret about this action?
No,
Mm.
I don't.
Do you have? Yeah, I can see. Okay, so so all these trials was just to give attention to your boyfriend. Am I right?
If you say so.
Did you try to harm others or only yourself?
Just myself.
How was your mood recently, Sarah?
I don't know, like I just can't forgive him anymore because I know that he's cheating with me. Because why else he will break up with me? I'm the most perfect girl in this world. I'm the most beautiful girl. Why he would cheat with me?
I see. Okay. And did you sleep well?
I can't. I just keep on thinking about why this bastard just wants to break up with me. I did everything for him.
Okay. And how is your appetite?
Yeah, it's okay.
It's okay. Okay. Did you feel sometimes you had a high mood?
No.
No. Good. Okay. How's your did you feel? I will just ask you some screening questions. So, did you feel, hear, or see something while other cannot?
No.
Did you think someone is spying on you or wanted to harm you?
I know that he's cheating on me. That's all I know.
Okay. Okay. Did you think someone is inserting thoughts on your mind or taking thoughts from your mind?
No.
Okay. And do you smoke?
Yeah.
How many cigarettes
20.
per day?
Yep.
For how long?
As long as I remember.
Okay. Do you drink alcohol?
Yep.
How much alcohol you drink every day?
I don't know, whatever I can get. Sometimes 5, 6 bottle.
Okay. For how long?
6, 7 years.
Have you increased this amount recently or the same?
Doesn't matter. Sometimes I do binge drinking. Sometimes I just don't do anything.
Okay. Did you take any other recreational drug?
Yes, I get whatever I can get from the streets.
Okay. Did you use IV injection as well?
No.
No. Okay. Do you have any medical disease I should be aware of?
No.
Are you taking any other regular medication?
No.
Do you have any head trauma?
No.
No other preferences?
No.
No fever or infection?
No. Go to your next task, please.
Okay, thank you. So, examiner, I would like to present the MSE examination of my patient Sarah, 24-year-old girl admitted in the ED with diazepam 10 tablet overdose after a fight with her boyfriend. For the general appearance, the patient is well groomed and kept wearing appropriate to the weather. Behavior, she's doesn't have any abnormal movement, but she looks anxious and angry about her boyfriend. He's cheating about her and whatever she's doing for him. He's not faithful for her, and for her speech, it was variable in tone, volume, and speed, but there is no rapid or high volume speech. Her emotion, her mood looks anxious and angry, and her affect is congruent to her mood. Her perception, she had no hallucination, visual, tactile, or auditory. Her delusion, she had no delusion of guilt or delusion of reference. I think she had some delusion of reference. She thinks that she's the most beautiful girl in the world, but no other delusion of paranoid or persecution. She doesn't had any suicide thoughts, but she had many trials to harm herself just to give attention to her boyfriend, to show him how she's loving him. For her, I can build a good rapport, even she was uncooperative at the beginning. Her history is reliable. I think she had some risk for herself because she had many trials. I didn't assess her support. If she had family support, also can aid to her risk of suicide.
All right. Thank you. Time is up.
Okay.
Thanks, doctor. So, Dr. Sarah, you did really good. And most of the important things you have asked, you did not. This was a hard case, right? Because I keep on screaming on you. So now, one of the learning experience about this case is sometimes in exam, the psychiatric patient will scream at you. They will not actually treat you how you'd like to be treated. And that is real life. In real life, you get to expose with this kind of patient. So, and this is how you learn how to deal with them, right? So it's very important to remain calm, don't take anything personally, and just go with the flow, which you did, which was really good given definitely you were also in the beginner stage. So in terms of that, you have done really, really good. So what's the most important thing which was not assessed in the history? Anyone, or even Dr. Sarah, what do you think you did not ask?
Like if she will go home, what she will do if someone will pick her up, what she's thinking, like if she want to, she will do this again, or
Yes.
don't know.
So did you specifically ask, I can't recall, did you specifically ask that, do you have any thoughts of harming yourself at the moment?
I don't think I asked
No.
about that.
No.
Yeah.
So I think you assume that because she already overdosed, that means she is suicidal. So we can't actually assume that, because see this question, she wants to go home now. Although it is not a management, but we need to know that whether she has any active suicidal thought right now. That means we need to ask those suicidal questions that, do you think life is worth living? Do you have any passing thoughts of harming yourself in a way that you want to suicide directly? Because she has self-harming behavior. So we need to ask that, do you have any passing thoughts of harming yourself in a way that you want to kill yourself or you want to suicide? Any thoughts of harming others? So those things are really important to ask in this question. This was a case of BPD, borderline personality disorder. I'm going to discuss this with you because this is fairly a new case, because nowadays even this kind of case they give it in the MSE. So let's see how this case should be done. So she had a fight with her boyfriend because she was not in the mood of talking to him. He was calling her multiple times and she just snapped. Started fighting over the phone. One thing led to another, and the boyfriend ended up to break up with her. So see that like this kind of information you would get if you would ask me, which means that when I said that I just wanted to show him how much I love, you needed to ask. Those things are important to explore, because I know we are running out of time, but we also need to find out that what actually happened. So you need to ask that, I'm sorry that you had to harm yourself to show him how much you love him. Is there any, like, can you please tell me what actually happened? What made you to do this? So then you will find out this important information, which is important information in here. Then we ask, yes, did you do it before? How many times? Then one of the other information you will get that I think he has got someone else. He must be cheating with me. Otherwise, why he wants to break up? I am the most perfect girl in the world. Now, that is a delusion. We can definitely say that this is a delusion of grandiosity. So that's one of the important things many of you will miss, because it's very, very subtle. Do you strongly believe that he's cheating? I'm not sure. I know he loves me. What else it can be? So this is called paranoid ideation. So you might think that whether the patient has got paranoid delusion, but it is not a paranoid delusion. It is rather paranoid ideation. So paranoid ideation means that patient feels that something is wrong, okay, but they are not sure. So in here you will say that, do you strongly believe he is cheating? Patient will say, I'm not sure. I know he loves me. What else it can be? See that they're just thinking that maybe someone is cheating them, but it's actually they're not sure about it. That's called paranoid ideation, not paranoid delusion. Okay? So also, if you explore a little bit, you will find out that this patient might be having all the features of borderline personality disorder. Like she has frequent mood swings, she gets angry easily, gets impulsive. You got a lot of drug use history as well. Now, is it necessary to ask these questions in here? Not really. If it is only history and MSE presentation, it's not must to ask all of these questions, but given you already know, you just by looking at the question, you know it is a BPD case. It's a good idea that if you're taking a history from a BPD patient, you explore their history at least a little bit. So these are quite important history that we should ask, okay? So based on a particular case, if we are not sure or the case seems to be like a OCD, right? Where we explored the idea of the thought, various rituals, compulsion. That means case by case, we explore a little bit about that particular diagnosis, which is a part of the history, which we need to definitely ask, okay? On the top of the MSc. So sometimes this kind of question also will come to you about like making a proper diagnosis, give a differential. So when we are making a diagnosis of borderline personality disorder, these are the specific questions we need to ask. So there is a DSM-5 criteria for BPD. So if a patient has 5 of the following, so one is frantic effort to avoid real or imagined abandonment. So you can understand that this patient feels that someone is cheating with, like her boyfriend is cheating with her. That's why she is starting to self-harm for attention because they have a fear of abandonment. Unstable relationships, so they will have multiple broken relationships. Identity disturbance. So many of these patients will have unstable self-image or sense of self. So this is one of the important things you can get in the MSc, that they can have overvalued ideas. These are the patients, they can have eating disorder associated with it. They can say that I feel overweight, I feel ugly. So they can also have those things as well. So you can get some overvalued ideas like eating disorder, body dysmorphic disorder, those kind of things can be associated in here. Impulsivity. So they will be very impulsive, like excessive spending, reckless driving, sex with unknown stranger person, lots of substance abuse. So these are very common. Recurrent suicidal behavior, affective instability. This is something you have got in this patient. Can anyone say that what was the affect of this patient? Labile. That's right. That's it. That's the one. Yes. So very good, guys. So labile, because remember the first time I started being very angry, and then suddenly I started crying. So all over the place, my mood was just in and out. Sometimes good, sometimes I get angry, sometimes I was answering questions, sometimes I did not feel like answering. That is called labile affect, which is a very important finding in a BPD patient because their mood frequently changes. So this is why it's important. In your head, you should know that what this case might be. In that way, you would be able to focus, because if you are not focused, you will miss this kind of finding, right? So affect was labile. Chronic feelings of emptiness. They will have inappropriate anger, which you have definitely seen in this case. and transient stress-related paranoid ideation or severe dissociative syndrome. So you might get a bit of a dissociation in here, like they can say that I can't remember some part of my life, which is dissociative amnesia, which will be part of perception. Okay, so that's one thing. You can get derealization, depersonalization in here, and you can get this paranoid ideation where they feel that someone is harming themselves or someone is cheating them, but they are not sure. So that is called ideation. They are still not completely convinced. When completely convinced that yes, this person is harming me, this person is cheating on me, that becomes paranoid delusion. When it is just idea, it becomes paranoid ideation. Okay? So in this case, we have got some of the findings in here. So before I present the MSE, let me explain if this was a case of diagnosis, how would we say? We would say that most likely you have a condition called borderline personality disorder. It's a mental health condition where patients have difficulty to manage their emotions and relationships. Often that can lead to self-harming behavior, marked impulsive behavior, and fear of abandonment. So when you explain, then you just need to say that this is what you have got. So sometimes this case comes as diagnosis differential as well. So you need to make sure you need to know how to explain them. So there was a video case of borderline personality disorder in the exam as well. Okay? So let's say that if we need to explain or present the MSE in here, how would we do it? So you will say that I would like to present MSE of my patient who is a 24-year-old Sarah brought by ambulance because she was overdosed with 10 tablets of diazepam after having a fight with her boyfriend. In terms of her appearance, she is well groomed, she is dressed appropriate to the weather, but she is quite angry. She is also she is showing frequent restlessness, agitation, and sometimes even she just wants to go home. Her speech was rapid and pressured most of the time, and also but there was no slow monotonous speech or disorganized speech. Okay, as part of his emotion, she did not answer to me about her mood appropriately, but the effect that I have observed, it looks labile to me because her mood, sometimes she is angry, sometimes she is sad and crying, so it's all over the place. As part of perception, she did not have any hallucination. Thought form was linear. Thought content, she had delusion of grandiosity because she thinks she is the most perfect girl in the world. She has paranoid ideation as well because she thought that her boyfriend is cheating on her, but she is not completely sure. He was also having suicidal thought. Now, if you ask me that, how do you feel? You might get a suicidal thought in this case. So in this case, in the thought content, there would be a suicidal thought as well, but there was no homicidal thought. Then depends on the insight, cognition, judgment was intact. If you finish those, then you just say that yes, insight was normal, cognition was normal, judgment was normal as well. She is high risk given she has active suicidal thought and delusional behavior. And I was able to maintain a good rapport with the patient. The history seems to be reliable, but still I would like to take a collateral history from the boyfriend. Okay, so that will be the presentation in here. So the positive points, the main positive points is the labile affect, delusion of grandiosity, paranoid ideation, and if you get a suicidal thought, that will be added as well. Okay? Clear, everyone? So there are lots of cases of MSc, we would not be able to finish MSc in one class. So what we would do in your batch as well, that there will be another class on MSc presentation, which will be also another role play session, but that is not a part of this free session. So when you join the course, we will also do few of the others, because you can see there are 128 page, which means there are still a lot of cases under the MSc. But you have got an idea that how these cases can come in your exam, how you need to take a history, how you need to do a MSc presentation and all. So that all that matters. And I hope that you enjoyed the session. I hope you are not scared of AMC clinical after this class at least, although it is very early to say. But as you can see that eventually with all classes, with all the theory discussions, more and more role play, you will get there. So all you need to do is to follow our guideline, follow what we are discussing in the class, and you should be fine. Do you guys have any questions? Yes, so those who have joined the course are getting access to the portal, Dr. Syra. And Dr. Anna, if a case points to a likely diagnosis, is it better to focus on questions related to the diagnosis? Yes, definitely. If there is a diagnosis case, all psychiatric diagnosis needs to follow the DSM-5 criteria. So that's why we show you the DSM-5 criteria and we show you what are the exact questions you need to ask. So like the BPD case, I actually forgot to show you that there is a criteria question there as well. So if you allow me to share it. So see these diagnostic questions for BPD. So these are all the questions. So do you do anything else to ensure that he doesn't leave you? Do you have any other past relationships? How many? What happened with these relationships? So you're getting the idea about the broken relations. How do you feel about yourself? Any impulsive behavior? Any frequent mood swings? Do you lose your temper easily? Do you constantly feel empty alone? Do you harm yourself to cope up with the stress? So these are the diagnostic questions for borderline personality disorder. If it is a diagnostic case, then you need to ask these questions one by one. If it was a MSc case, then at least few of these you need to ask. Like we have asked in here that mood swings, gets angry easily, impulsive, all of these we are asking in here, which you should ask even in a MSc case, just to gather the information about the patient. Okay? Again, because a lot of you will have questions about it. It is very important to know that the old website is no longer being used. So we have a completely new website. So the first thing you should know that if you just write first aid AMC in Google, there will be two websites. So please do not go to our old website. So if you come to First Aid Medicine, that's where our new website is. This is a very updated website, and we're trying our best to give the best user experience when you are actually part of the course. And we are working on it every day. So if you go to this 5 months clinical course, you will be able to go through all the details. So the course has started today. From 15th of June, it will end on 30th October, or maybe if we need, we might need like maybe 1 week of November. we will try our best to finish it in October, but sometimes it can go to November first week. We did a trial class on 25th of May. And if you have missed that class where we discussed a lot about AMC clinical exam, and we did a little bit of psychiatry, which was the MSE history, this is the recording of it. The free 2 weeks classes are super important. I always say that even if you are not joining the course, do this class because you will get a lot of information, which will be immensely helpful for you. So join our 2 weeks classes as per the schedule given here, just like how you did today. So the Zoom ID and password is also given. Your next class will be, so today is 15th, so 16th. So tomorrow you are also having another class. That class is completely random, which means that I normally don't do the random role play. Dr. Cynthia, Dr. Samira, they are the role play mentors. So you will get to do random cages role play, which means now this is going to be hard. This is going to be interesting because you don't have much of an idea about the cages. But why we do it? We do it to give you that feeling that how exam will look like. Exam will give you questions from every topic, and you just need to perform. Initially, everyone struggled to do this class, but don't worry because this is just to give you that feeling that if I get a new case in front of my eye, how am I going to perform it? That is what you get the experience. Because AMC clinical exam, you will always get new case in your exam. Whatever we do, there will always be some new cases. Okay? So you need to be prepared for those. So if you feel overwhelmed in these random role play sessions, think that it is common. Everyone feel the same. Okay? But the theory classes that I'm going to take, you should not feel overwhelmed because I will take you through it. I will gradually go through just like how we have done with the MSc. The other classes will be like this. Random role play classes gets interesting and more interactive after a few months of the course. These are the course inclusion. We have refined this course in a way which was like this is the best version of the course we have ever been. So you can understand that even without the best version, our students were passing the exam as the most passing candidate rate in all courses in Australia. So now we have made it much better, especially with the new website. The things will be much easier to find now. It will be, you will get an idea that it's very easy to find out, you know what to read. So it will be very interactive and user friendly. That's really important. Other than that, we have added few more things like you will be able to do one-to-one role play with our mentors. You will be able to do one-to-one job session related queries with our mentors. Although that require a small subscription fee, but those will be worth it. And another thing is that we are also arranging a face-to-face physical examination, kind of like it's a comprehensive hands-on with mannequin. We will be doing a symposium, most likely at the end of the year, and then it will become regular in the next year. So that's really like we have never done it, but we are going to arrange that because it is a face-to-face exam. So we'll show you how to do physical exam. And also, another important thing that we have added is that nowadays you will also get all the past class recordings. So what we do that, let's say someone wants to finish the course within 2 months. So you also get that thing. So we add all the previous, just the recently finished course, which has like all the updated materials anyway. So we upload that in your website as well. And you can also finish the course. You can at least finish the theory classes because theory classes are more or less same, but we still add few things in the new course all the time. But you will get a bit like a good knowledge about the course just by going through that recorded sessions. So all our previous batch recorded classes will come to your portal. including all the role play sessions we have taken in the last 3 years. So there are currently, we are doing 214 role play class. So you will get, out of 200, you will get at least 150 role play class in your portal, which is a lot. It will cover all the cases that might have come in the last 3 years. And that gives you a lot of idea about the exam scenarios, how to prepare and all. So basically, the course is divided into theory-based, which is how we are doing this. So all the theory sessions will be with me. We will do role play on the theory-based clusters, like we did a MSc, then we're doing a role play on the MSc, like that. You get 5-year role play, which means all the sample case that is important for your exam throughout these years from 2021. All those notes, the recordings will be there in your portal without any additional fee, which is a lot of materials. We do physical examination based on the face-to-face format, but we also cover online format if we get a lot of online students, but mainly face-to-face format. And we reserve 1 month for the physical exam because we know physical exam is really important for you. So I can assure you that with the physical exam that we are going to show you, you will not fail in your physical exam. Okay? And also there will be recordings of all these classes in your portal with extended access. We will not say that you will just get it for 1 month or 2 months. It's not like that. So this is the only course in Australia who has prolonged recording access. It's not just for AMC, any course. So any course that you will ever enroll in Australia, you will always say that Dr. Arshan's, that was the course where we have got 10 months, 15 months access. Because all course will give you maximum. I've seen that one course, the cost would be maybe like $3,000. They will give you access for 5 months, 6 months. One course, they might be having like multiple broken fees, but you just get access for maybe 1 month, 2 months. Other course, their course fee is $5,000, $10,000. You don't get any recordings. So there are lots of courses like that. So we know that no one can finish this within a month. So you need recordings to go through this. There are extensive materials. There are extensive, like you can assume that you need to give a lot of time to prepare for this exam. And we can't just ask that Dr. Sarah just read with me for the next 6 months. Do not do anything. Do not go to your work. We can't say that. So you have your own way of life. You have lots of other responsibilities, and this recorded process is going to be really, really helpful for you. The night before your exam or week before your exam, this is the most important thing that you will miss. So we make sure that you get those recorded class and you get that enough extended support that you would need. And this is vital for any clinical preparation. For MCQ, I would not bother about recording, but for clinical, recorded classes are super important. So that is all that we have in here. So you can go through these details if you like. And for registration of the course, I would strongly suggest that, because getting the access to the course take a bit of time. At least nowadays it takes 3 to 5 days to get into the portal, because there is a lot of students who join our course. So make sure that if you feel that this is the right course for you, I would suggest to just join now and start the preparation, because we have given access to the portal for all the paid students. Okay, and also you get, so for clinical course we have installment policy as well, so you can make half payment, and then you can do half in the next 2 months. So that's also another. It is convenient for a lot of people. Okay, so that's all about our clinical course. Hope that you are enjoying the sessions. Join our classes as we have given in the schedule, and I'll see you in our next batch. Dr. Dej, yes, there will be a special group for finding a study partner because you will see a lot of other students. You might even find someone who is in your own time zone in the course. So joining the course, there is a benefit that you get to know others, you get to make friends, and you get your study partner from the course. And that is the way to do. For role play, Dr. Bora, there is no CPD certificate. It is just for the full course. So if you're referring to the role play course for existing student, just please send me a message in my inbox. So tomorrow's class will be random from any subject, not related to MSc. And face-to-face workshop, yes, we have a plan to do that in Sydney as well. Here tomorrow, the Dr. Cynthia will take the session. I'm sure you will enjoy that, but don't get scared because those random role play sessions can be quite stressful, can be quite overwhelming, but she'll explain everything with you and you'll get to enjoy those sessions as well. Okay? Thanks everyone. Have a good night. Take care. Dr. Saira, so there is another one which will come today. So that 17th page is just the MSc history. So this class, which we are taking now, it will be uploaded tonight. You will see that, okay? All good. Take care, guys. Thank you. Bye.